This program is brought to you by Emory University.
All right, everybody, good morning. Thank you, everybody, for coming. Hope everyone's got their coffee. Been trying to organize this one for a while now. It's a great pleasure for me to introduce Pradeep Natarajan from MGH in the Broad Institute at MIT. He's going to tell you about some of his research on genomics with coronary artery disease. Pradeep has been in Boston now for quite a while. He was at the Brigham for residency, Mass General for fellowship. He trained in Sek Cathareeson's lab, which is one of the foremost labs for this type of research in the world. And he's now off on his own. And he actually just found out that he's graduating his K to an R01, which is big news. And he collaborates with some of our folks here. I see Karen Keneally in the back and Peter Wilson through the Million Vets Project. So I won't beat a dead horse here. I'll just turn it over and let him take us through his slides.
Thanks, Mike. Thanks. Thank you all for coming. So we'll get started. So my disclosures. So here's a common scenario that comes to a preventive cardiology clinic. I'm sure these are the kinds of folks that you guys are saying here. And this, these kinds of presentations really form the basis of what I think about in the research that I do. So a common scenario is, I'm young, 35 years old, often somebody in their 30s or 40s, healthy, active, don't smoke, but dad had a heart attack at 50. And so the implicit or often explicit questions are, am I going to get a heart attack as well? And is there anything that I can do about it? And really what forms the basis of these questions, is work that's, almost a decade ago. And there was this seminal collaboration between Dr. Samuel Levine at the Peter Bent Brigham Hospital and Paul Dudley White, who founded our cardiac unit at MGH, to really start to understand why individuals get premature coronary artery disease. This was not an issue really until the early 1900s. Prior to that, people were dying of a variety of other cardiovascular disease conditions. But, coronary artery disease and myocardial infarction was becoming so prevalent that people were starting to die young. So they ascertained a cohort of about 100 individuals across all the various Boston hospitals who had an MI less than the age of 40 to try to understand what the root causes were. And, a big observation was that cholesterol seemed to be elevated among these individuals. About less than a decade later, Franklin Roosevelt died of complications related to high blood pressure. And there was this general notion that, coronary artery disease was becoming a big problem. We really didn't understand the root causes and how to prevent this. So there was this Inter-Society Commission in 1970, headed by Jeremiah Stamler at Northwestern and Abe Lilienfeld at Johns Hopkins, that really aggregated many of the different parties together to try to put forward a statement. And so I'll read this, and they said, in view of the fact that atherosclerotic complications cause the majority of deaths in this country, substantial proportion of disability, it's recommended that immediate efforts be made to prevent premature atherosclerotic complications. They said that this should be U.S. policy. So the basis of this statement and various other pushes was the basis of this big trial, the multiple risk factor intervention trial, or Mr. Fit, where they took individuals that had multiple risk factors and basically applied intensive preventive therapies. And a key message from that trial was that individuals that had multiple risk factors are more likely to benefit from preventive strategies. So that was basically the basis of the first cholesterol guidelines as we know it in 1988. It basically recommended individuals that had multiple clinical risk factors should get intensive preventive therapies. In 2001, that's when statins were widespread. Some of the initial clinical trials were reported in the mid-1990s. That was advanced to the recommendation was we should be using statins. Also key was instead of just saying, let's take multiple risk factors, this was advanced to a single score, the Framingham risk score. This was advanced by Peter Wilson and others, where now we have a single score that say this individual is at this risk, so we prescribe a statin. In 2013, that is made more generalizable with the pooled cohort equation, so for multiple different ethnicities. And in 2018, pretty much the same with some nuances. So the pooled cohort equations, I'm sure the screenshot many of you guys know. This is the web portal from the ACC website where you can put in the conventional risk factors and you get an estimate. And a key limitation, but probably appropriate, is that age is the dominant risk factor. This is a really nice simulation from Clonal, Carmali, and Don Lloyd-Jones at Northwestern, where if you take individuals, so each of these bins are basically deciles of age. And then if you look at each of the conventional risk factors and you increase from lowest to highest, and the y-axis is estimated risk, if you're young, it's really hard to cross that magical threshold of 7.5%. And if you're old, you're pretty much always above that. So, that's reasonable because, older people tend to get cardiovascular disease, younger people don't. But, if we get back to, some of the initial impetus for the cholesterol guidelines that we have it today, a big focus was really to identify individuals who are at risk for premature complications. So if we get back to our patient's initial question, am I destined to get a heart attack as well? It's actually really hard for our patient within our current paradigm using, the pooled cohort equations or the Framingham risk score. So what's the, basis for, at least, the genetic basis for premature cardiovascular disease for individuals who might get myocardial infarction at an early age? And the well-recognized genetic syndrome is familial hypercholesterolemia. In the late 1900s, it was established as a dermatologic condition, and then in the early 1900s, it was recognized that these individuals were dying of premature coronary artery disease. But really, the molecular basis of this condition was established by Michael Brown and Joe Goldstein at UT Southwestern, where it's about 1 in 200, 1 in 250 individuals largely have a genetic defect in the LDL receptor. This is the gene product is the receptor on the liver surface that's responsible for clearing LDL cholesterol from circulation. And so if individuals aren't able to clear cholesterol, LDL cholesterol is high and they're at marked risk for premature cardiovascular disease. An important observation from the work was that because the liver wasn't sensing cholesterol, it was also increasing the expression of an enzyme to synthesize cholesterol. That's HMG-CoA reductase, now obviously the target of statins. And this body of work was the basis of a Nobel Prize in the 1980s. So that's a minority of individuals, still reasonably prevalent if you think about monogenic diseases. What about in the general population? And we'll go further back when Don Lloyd-Jones was a fellow, and he was working with Chris O'Donnell at the Framingham Heart Study. Chris, many of you guys collaborate with, is now the chief of cardiology at the Boston VA. And they looked within the Framingham cohort and said, if you take all the risk factors aside and you said, if somebody has a parent with premature cardiovascular disease, what's the fold risk for you? And this is, in the unselected general population, representative of, Framingham being representative of that. And it's basically a twofold increased risk, roughly similar for men versus women. What's interesting is the Framingham risk score, included family history in its equation. The pooled cohort equations doesn't. And that's probably the right thing because, family history can operate through conventional risk factors or maybe orthogonal to that as well, too, which we'll talk about. But a helpful, back of the envelope calculation is this, this factor of 2. So, these observations form the basis of doing just broadly genetic studies in the general population. So this observation that, if premature cardiovascular disease happens in families, it tends to aggregate in multiple individuals in the family, or, there's some excess risk if parents or first-degree relatives have premature coronary artery disease. So that has led to so-called genome-wide association studies, been a big basis of population genetics research over the last decade or so, where you can take groups of individuals, individuals that have had coronary artery disease and individuals that have not, broadly genetically profile, and we look for genetic markers that are enriched or depleted in one versus the other. And so these obviously get larger and larger, and one of the latest was led by an MGH surgery resident, that's Derek Claren, who works with many of us. So Derek and others, these are obviously very large efforts, usually we're amassing multiple different data sets and bringing them together. This is an example of the output of those kinds of studies. This is a circularized representation of the genome, and each of these dots represent markers that have been profiled. And the further they are away represents how strong the association is with coronary artery disease. And there's roughly about 200 different regions of the genome that are associated with coronary artery disease. Turns out about 40% of those regions that are significantly associated with coronary artery disease map to conventional cardiovascular disease risk factors, meaning the majority we actually don't have a good hypothesis on why they influence coronary artery disease, and that's the basis of a separate field of research, related field of research. But one can leverage these observations also for risk prediction. So this is the concept of developing a genetic risk score where we can take each of these and consolidate it into a single number. So if you take each of these risk, these different regions that are associated with coronary artery disease, and we take the allele that's been associated with coronary disease, in the discovery cohort, we have an effect estimate attributed to what's its fold risk with coronary artery disease. Each of these are essentially independent risk factors, and so you can additively sum them up to get a single score. So one of the first demonstrations of this, at least as it applies to coronary artery disease, was led by Sumali Rapati and my postdoctoral mentor, Say Katharaysan. This is when there was about 10 variants or 10 different regions of the genome associated with CAD, and they looked at a cohort in Finland and showed that if you summed, essentially the number of alleles by their individual effect estimates, you can predict orthogonal to conventional risk factors future risk for coronary artery disease. Fast forward to today, where these studies are much larger. I said there's about 200 different regions associated with coronary artery disease, but there are advances in statistical genetics where we can actually use more than 200, so even upwards of 1 million, to really refine this polygenic risk score. What Mike Inouye and colleagues have shown here is if you look at the discriminative capacities of conventional risk factors, that's each of these here within the UK Biobank. This is 500,000 individuals with genotypic and phenotypic information, and then you layer on this polygenic risk score. In isolation, it shows a comparable discriminative risk score, but if you layer it on top of conventional risk factors, it's giving you additional information. One thing that I find interesting, and I think relates maybe more to our patients that we're seeing, is that genetics is unique in that you can profile this really once, and it can be as early as birth, and establish some trajectory, and really could be the first risk factor that you think about for patients. And we'll talk about some of the issues and opportunities with that concept. Work led by Amit Kara, a close colleague at MGH in Sake's lab, said that if you look at the tails of the distribution, again, this is a continuous normally distributed score, these individuals that are at markedly increased risk. So if you actually look at the top 5th percentile, 1 in 20 individuals, their fold risk for coronary artery disease is similar to familial hypercholesterolemia, not clearly operated only through LDL cholesterol. And familial hypercholesterolemia was about 10-fold less prevalent. Okay, so if we've established a trajectory from birth, I think an important question is, can we do anything about that trajectory? Is that trajectory modifiable? This is work also led by Amit. This is using an older polygenic risk score and multiple different cohorts. If you separately look at individuals' lifestyle patterns, and then you also look at their genetic profiles, individuals that have high genetic risk, who have a favorable lifestyle, have lower event rates. This is an important message. It was actually not that surprising, again, because each of these are independent additive risk factors. Lifestyle is separate, genetics is separate, but it's important to say that if you have a predisposition to coronary artery disease that is not changing, which is the genetics, other things that you can do can actually influence that trajectory. And that concept has been advanced with multiple different cardiometabolic diseases. This is, again, using data from the UK Biobank. Okay, so lifestyle works, and that works for everybody, and there's I think separate public health challenges in implementation of that. There's some notion that if you identify high-risk individuals and you tailor your approach that way, that may be more cost-effective. But what about medicines that we use every day for prevention, like statin medicines? So the current approach, which hasn't really changed from the 2018 guidelines, is you estimate risk and your basis for giving somebody a statin medicine is high absolute risk. In pretty much every subgroup analysis, or every clinically defined subgroup, the relative risk reduction is the same. So for about 40 milligram deciliter lowering of LDL cholesterol, you lower risk relatively by about 20%. So if you have, diabetes, you're older, smoking, the relative risk reduction is the same, but you're magnifying the absolute risk reduction, lowering the number needed to treat just because you're starting at a higher absolute risk. Okay, so what about our genetically defined groups? So in familial hypercholesterolemia, at least today, nobody's going to do a randomized control trial of statin versus placebo to see if the relative effect is different. But if you look in retrospective studies, this is work led by Jan Besling et al. If you look retrospectively, individuals with molecularly confirmed familial hypercholesterolemia are placed on statins. There's actually a greater relative benefit. So, in all comers is about 0.8 for the hazard ratio, and here 0.56, so about a 44% relative risk reduction, meaning they're at higher absolute risk, but also a greater relative opportunity for benefit. So that's 1 in 200 individuals going through LDL cholesterol. Now, tenfold more prevalent is high polygenic risk score, similar effect estimate, so about a threefold increased risk for myocardial infarction. Now we have the opportunity to look within randomized controlled trials of statins that had the foresight of banking whole blood, where we can actually extract DNA and do the similar genetic profiling and calculate polygenic risk scores. So we went through many of the legacy primary prevention trials and looked separately what is the relative and absolute benefit for individuals who are at high polygenic risk versus the rest of the population. And surprisingly, these individuals also had a greater relative benefit from being placed on a statin. So again, higher absolute risk, so greater opportunity for benefit, but the relative risk reduction was further maximized, further optimizing the number needed to treat. So in unpublished work, we asked, is there, are somehow clinicians recognizing this? In epidemiologic studies, this is not associated with family history of premature cardiovascular disease. So we said, are clinicians somehow astute in detecting this? And so now we've looked at 3 different, real-world cohorts. These are hospital-based biobanks. The polygenic score still associates with coronary artery disease to a similar degree. This effect estimate is per standard deviation, but for the top 5th percentile, it's about 2.5 to 3-fold. And their statin prescriptions are the same. So I think there is an opportunity, a preventive opportunity for this. And if you think about actually the framework for the 2018 guidelines, where we say where there's clinical equipoise, in borderline intermediate patients now, which is actually a larger group of patients, we can use these risk-enhancing factors. And the basis for that is, simply establishing that it can, increase somebody's risk because it has an effect estimate that's statistically significant after accounting for conventional risk factors. So that's been established for this, but also it shows that these individuals may actually benefit more from earlier statins. But there are many, I think, considerations before clinical implementation, and there's some ways that patients are able to get this in the clinical setting, which we'll talk about. But there really is no official CLIA test yet. Many folks are working on this, and probably within the next 12 months there are. The 2 papers, or the 2 latest papers that I talked about, somebody can go and through publicly available websites, download these effect estimates and calculate their own polygenic scores if they've had direct-to-consumer testing. But it's actually fairly cumbersome to do. There's a portal through the Scripps Institute where, again, there's a research disclaimer where you can port over like 23andMe and Ancestry.com data and get a score. And this is using older iterations of polygenic scores, but they're updating it for this. I think a key limitation that a lot of people are uncomfortable with is that, because these, polygenic scores were developed in genome-wide association studies of individuals largely of European ancestry, we're pretty good at predicting future coronary artery disease risk, at least by a genetic risk score for individuals of European ancestry. It is predictive in non-Europeans, but less so. This is work led by Alicia Martin, who's a postdoc at the Broad with Mark Daly. looking at 2 different biobanks, so a biobank in Japan and the biobank in the UK biobank, where they developed polygenic risk scores for a bunch of different traits. And pretty much always in the UK biobank, individuals largely of European ancestry, there was greater model fit for these polygenic risk scores. It doesn't mean that Europeans are more susceptible to genetically mediated exposures. It's basically just an issue with the initial designs. And as we do more and more population genetics research in non-Europeans, I think these gaps will close. But there's the additional complexity that many individuals don't neatly fit in single ancestry bins. Many individuals are admixed of multiple different ethnicities. And we and others, and particularly Alicia, or with Alicia, we're looking at ways to address this. So that will involve basically new methods in addition to more non-Europeans. Also, a polygenic score doesn't, incorporate all of the genetic variants that we know influence coronary artery disease. So, familial hypercholesterolemia is not part of the polygenic score. There are other types of genetic variants called structural variants. These are larger changes in the chromosome that we know have been associated with coronary artery disease. Here's an example where we did a comprehensive genetic analysis of lipoprotein a, which is a strongly heritable risk factor that influences risk for coronary artery disease. And using a single genetic test, whole genome sequencing, we were able to parse out these different factors. But also, I talked about lifestyle statin, whether we should be doing, that similarly for everybody at high genetic risk. We don't know if that's the right answer. This is a hypothesis that has been put forth by Mark McCarthy from the UK, talking about type 2 diabetes, that if you look at the different risk alleles or risk loci for type 2 diabetes, they seem to influence diabetes in multiple different mechanisms where you can sort of potentially subclassify individuals, saying that their genetic predisposition to diabetes is this pathway versus somebody else, which is another pathway, and the pharmacologic approach may be different. That may or may not hold in for coronary artery disease. This is work that we're doing in collaboration with a group at Yale, Hongyu Zhao's group. If you take these larger genetic risk scores that I talked about, and we parse it out based on the known pleiotropy, the known associations with other risk factors, the profile with the various different risk factors are different. So it's possible that when people are genetically predisposed to CAD, you can potentially leverage at least the known risk pathway differences that we observe. And the therapies may be different, but we don't know yet. Another challenging I highlighted, you can identify genetic predisposition at birth, but we're not advocating putting newborns on statins. So the timing of this and the timing of risk refinement, I think, remains an outstanding issue. So this can involve additional biomarkers, can involve imaging. There's increased emphasis in the 2018 guidelines of using cardiac CT to also refine risk when there's clinical equipoise. And that could be done here as well. In 2 different cohorts, we observed an older cohort and a younger cohort. Individuals that are genetically predisposed to these clinical events are also predisposed to atherosclerosis as detected by coronary artery calcium. So you can imagine this could move the needle back for when you would want to do this kind of imaging or other assessments. But I think, in the end, to also move the needle on implementation for an actionable change is prospective clinical trials. The work that I showed earlier with Krishna Aragam in my group, where we basically are defining the cohort of where the clinical need is. We now have an opportunity to now do these clinical trials. There are many large healthcare-associated biobanks and non-healthcare associated biobanks where we have individuals with genetic phenotypic information where we have the ability to call them back really based on molecular profiles and start to do these kinds of clinical trials. So let's move this forward into PCSK9 inhibitors. These were also incorporated in the 2018 guidelines. And in the primary prevention setting, we think about genetics sometimes and thinking about PCSK9 inhibitors. So this is how they're incorporated into the 2018 guidelines, where we say, if you have severe hypercholesterolemia, kind of regardless of the etiology, you're a candidate for a statin medicine. If you've not achieved suitable LDL cholesterol lowering, you can consider ezetimibe. But then, if you want to retain that stringency of LDL cholesterol lowering, if you've established heterozygous familial hypercholesterolemia, then it would actually be reasonable to consider a more expensive medicine like a PCSK9 inhibitor. So, it turns out most people who have severe hypercholesterolemia don't have familial hypercholesterolemia, meaning a monogenic mutation in LDL receptor or ApoB or PCSK9. It's about 1 in 50 of such individuals. And we have very good clinical criteria for, saying, whether somebody may have these mutations. But, even in the best case scenario of, definite FH, which is, minority of individuals, very small number of individuals who have severe hypercholesterolemia, it's only about 1 in 4 who are going to be positive based on the test. So again, if we do, a very comprehensive genetic test, we did, very large whole genome sequencing test of plasma lipids, where we can look at the monogenic determinants, so whether they have an FH mutation, but now also polygenic risk scores and structural variants. So if you look at individuals who have severe hypercholesterolemia, I said about 1 in 2 individuals has an FH mutation. Now, about 1 in 5 individuals has a polygenic predisposition to severe hypercholesterolemia that's similar to familial hypercholesterolemia. And today, many insurance companies ask us to do FH panel testing for these patients. And these patients that have an equally strong genetic contribution to their severe dyslipidemia, they would be denied PCSK9 inhibitors. So now, moving on from risk prediction to therapies, can we leverage our insights from coronary artery disease genetic studies for new therapeutic targets? The hallmark of this is PCSK9, which we just talked about. There's a cohort of patients recruited by Marianne Abifadel and Catherine Boileau of patients who had apparent autosomal dominant familial hypercholesterolemia but didn't have the characteristic mutations, had very high LDL cholesterol and increased risk for coronary artery disease, and through gene mapping strategies identified PCSK9 as likely the causal gene based on other subsequent future work. And then Helen Hobbs and Jonathan Cohen at UT Southwestern showed that primarily among African Americans, there's 1 in 100 naturally carried a loss of function mutation in PCSK9 that had lower LDL cholesterol and lower risk for coronary artery disease. And this was later characterized as gain of function in that first story. And it turns out there are similar mutations in Europeans, just less prevalent. So, what was also an interesting observation is that by chance in, one of the cohorts from Dr. Hobbs's group, I think it was from the Dallas Heart Study, by chance there was one individual that happened to inherit one loss of function mutation from dad and one from mom. And so she was naturally deficient of PCSK9 at the time she was 32 years old. So she'd been living her whole life without any circulating PCSK9 in her body. Her LDL cholesterol was 14 milligrams per deciliter, and she was fertile and fine. And so, the pharmaceutical industry was obviously off to the races. And today we have at least 3 cardiovascular outcomes clinical trials for PCSK9 inhibitors and 2 PCSK9 inhibitors that are in practice. So we asked, are there non-LDL targets that could follow similarly this PCSK9 paradigm, where you have protective, rare disruptive mutations in the general population that apparently seem to confer some natural benefit for coronary artery disease that could be a drug target? And then separately from the safety side, would there be individuals that actually lack both copies? So a gene that we were interested in is ApoC3, the product being apolipoprotein C3. This is an apoprotein that sits on triglyceride-rich lipoproteins that's involved in the regulation of these other levels through a few different mechanisms related to clearance, hydrolysis of triacylglycerol, and then also the synthesis of VLDL, which is the major carrier of triglycerides in the fasting state. This is Tony Paulin and Alden Schuldiner, who had primarily done work in the Amish about a decade ago. They noticed that there was actually a lot of Amish individuals that had very low triglycerides, and a major reason was they had a founder mutation, a loss of function mutation in ApoC3 that was responsible to very low triglycerides. And it turns out in the general population, about 1 in 200, 1 in 300 individuals also naturally occurs a similar loss of function mutation in ApoC3. They have lower triglycerides, lower subclinical atherosclerosis, and lower future risk for coronary artery disease. Very similar to these initial PCSK9 story. But a key concern was that there was about 100,000 individuals that were studied at this time, but there was no loss of function homozygotes, meaning in this data set, there was nobody who had 2 copies. And so there was some concern from a safety perspective, for some reason is this being selected against. If you just looked at by chance, by Hardy-Weinberg, you would have expected maybe 1 or 2 individuals, so it's possible we could have gotten unlucky in these initial efforts. But we took a different approach to try to identify a group of individuals that may be enriched for these kinds of genotypes. So one can use use consanguinity or inbreeding. So imagine a loss of function allele just arises randomly, gets passed down to kids, also by chance, and they go on to have kids, and then let's say these first cousins have a child, assuming that is viable, but there's about a 1 in 4 chance that that child will inherit basically that same loss of function allele twice. It's technically termed autozygosity. So then if you look at the prevalence of consanguinity in the world, there, some regions of the world, this is more common for a variety of different reasons, often cultural reasons. And then if you look at our initial studies of European individuals, we found no homozygotes. We established a collaboration in Pakistan where the prevalence of consanguinity is amongst the highest in the world. And in 10,000 individuals, we found the world's first ApoC3 homozygotes. We took it a little bit further because the next natural step in these gene discovery analyses is to then model this in the lab. But we had a unique opportunity where we had ApoC3 knockouts who were humans. This is the target organism. And so we took families that had ApoC3 knockouts, and we took non-carriers, basically wild type and knockouts, and did some provocative experimentation. So this was, we hypothesized that if individuals were exposed to a fatty meal, they were less likely to have postprandial lipemia. That separate exposure has been associated with atherosclerosis. And so Danish, who's up in the corner, is the PI of the overall cohort, went to these villages and gave them basically milkshakes, and then we sampled their blood at different time points. You can see those who were wild type did not have a substantial excursion in postprandial lipemia. But there are several outstanding questions. I think it's a unique opportunity to have humans because the landscape of ApoC3 before were mouse models where it was not clear where the fat went. Some of the mice would get steatohepatitis, meaning the fat would accumulate in the liver. We know that humans don't get steatorrhea. There's actually a bunch of follow-up analyses we're doing to try to understand what the transport of triglycerides is in these individuals. But this is a druggable target. There is an antisense oligonucleotide for ApoC3. It's currently, has an orphan drug indication for lowering triglycerides, but whether this strategy lowers risk for coronary artery disease, we don't know. So we'll go on the last part is, the age I said is the most important risk factor. It's not something we really think about in genetics except for earlier age, but can we actually leverage older age being the dominant risk factor for a genetics analysis? So we know that blood cells influence atherosclerosis, is obviously a long body of work establishing that. And as individuals age, we also acquire mutations, and particularly in cells that continuously recycle themselves, there's an opportunity for mutations, and then also mutations that select for an advantage. So in blood cells, it's estimated that every 10 years there is a mutation that occurs within one of the genes themselves. Most of these will have no effect on that hematopoietic stem cell. Some will lead to that that clone dying, but a small fraction will lead to expansion of that clone. That term is clonal hematopoiesis. And then there's this phenomenon that's been described, clonal hematopoiesis of indeterminate potential, which is really a pre-malignant state, where some subset of individuals would then go on to develop leukemia or other dysplasias. So this notion was hypothesized a couple decades ago for a variety of experiments, but what really established that this occurs was the ongoing work that all of us were doing in population genetics of exome sequencing. So exome sequencing is looking at the protein coding changes of DNA, which we look at the germline. But it turns out the way that we do it is from whole blood. We take out the white blood cells, extract their DNA, and then profile the DNA of those blood cells. We can actually use separate software, separate statistical approaches to also then separately look at the acquired mutations. So this is clever work led by colleagues looking at the various data sets that we were developing at the Broad Institute. One that I was involved with particularly was led by Sid Jaiswal, who was then an MGH pathology resident, where he collaborated with David Altshuler before David left for Vertex, where David basically gave all the exome sequences that were being generated to study type 2 diabetes, and then Sid just used the separate software. And so there's a few papers in 2014 that suggested that this phenomenon was present, and as people got older, people were more likely to have clonal hematopoiesis. Again, asymptomatic healthy individuals that had a pre-leukemic state. Individuals in their 70s is about 1 in 10 individuals. So in Sid's paper, Sid was a postdoc at the time with Ben Ebert at Dana-Farber. They showed that, and there was another paper that showed that if you had this condition, there was an increased risk for future mortality. But then they also did cause-specific analyses, and surprisingly, it was not because of cancer death; it was because of cardiovascular death, and this was an interesting exploratory analysis. But interestingly, consistent observations in coronary disease and ischemic stroke. So we wanted to evaluate this further. This was a collaboration with Ben's group, with Sid. Sid's now at Stanford, and with Peter Libby, where we took data sets that SAIC was generating for the purposes of analyzing germline predisposition to coronary artery disease, and again, used a different statistical approach to determine the presence of clonal hematopoiesis and confirm that individuals that had clonal hematopoiesis had an increased risk for coronary artery disease. So if you looked at conventional age-associated athero, about a 2-fold increased risk. But surprisingly, individuals who are young, who happen to have clonal hematopoiesis, is about 0.5% of individuals, had a 4-fold increased risk for premature myocardial infarction. That relationship of prevalence to effect estimate is similar as familial hypercholesterolemia. We also observed that also in humans, there was also a predisposition to subclinical atherosclerosis as detected by coronary artery calcification. And then in mouse models, so if you take an atherogenic mouse and you essentially mirror clonal hematopoiesis by doing a bone marrow transfer of TET2 deficient, so TET2 is one of the implicated genes, into the bone marrow of that mouse compared to wild-type mouse with controlled bone marrow, the mice with essentially clonal hematopoiesis have more atherosclerosis. This work was also similarly done by Ken Walsh's group with Jose Fuster, who's now in Madrid, where they did relatively similar model and showed the same thing. But what they also observed was that if you inhibited a specific inflammatory pathway, the IL-6, IL-1 beta pathway, that can mitigate the atherosclerosis in this model. So that was pretty cool. If you guys remember, there's a clinical trial, the CANTOS trial, that looked at individuals with atherosclerosis who had high markers of inflammation, gave them an IL-1 beta inhibitor, canakinumab, shows about 15% relative risk reduction of events in that setting. And so Novartis, for a subset of these patients, did targeted sequencing of these genes to detect for clonal hematopoiesis. Turns out there's actually a higher prevalence of clonal hematopoiesis in the CANTOS trial, but the individuals that had clonal hematopoiesis who were given canakinumab had a markedly greater relative benefit of being on canakinumab. It's about a 66% relative risk reduction. That's something that we don't really see in cardiovascular clinical trials. That certainly needs to be evaluated prospectively in a separate trial, but really consistent with the mouse observations. So these prior observations of clonal hematopoiesis were in data sets of about 10,000 individuals. We are now doing this in much larger data sets. This is doing this in collaboration with Karen Keneally here and others. And nice opportunities to look at mechanisms also within the intact human. So in summary, coronary disease is heritable. We can leverage it for early risk prediction and also use it for drug target validation and discovery. That trajectory of CAD genetic risk can be offset and altered by healthy lifestyle, also medicines like statins. And then separately, somatic mutations in blood cells are common. They predispose to CAD. There may be separate strategies that one would want to use if that was present. And then there's an opportunity for now whole genome sequencing. This is kind of like the gold standard that is now feasible to do at population scale, where we can look at all the genetic determinants, the diverse germline spectrum, but now also the somatic spectrum within a single test. So we'll end it here. This is a picture of Paul Dudley White with Mary Lasker receiving one of the first Lasker awards, and he's really credited for being a big basis of of what preventive cardiology is today. But there are occasional patients that show up with the polygenic risk scores in hand, and there are many questions about what you should do. And this happens to me about once a month, and I think part of it is just being like next to MIT and having enterprising grad students and postdocs. But there are some other people that have come through various concierge practices that somehow offer these things. And I think first thing importantly is to connect with population geneticists, and there are certainly some here, Peter and others. And some of the issues that we've seen, obviously is there are disclaimers because most of this stuff is not clinically appropriate yet, at least not endorsed by FDA, and not adhering to CLIA standards, especially if they're going through direct-to-consumer testing. And the reporting is very much the Wild West. I saw somebody last month who got this through one of these practices and was billed as saying, there's many different genetic variants that are associated with CAD with this patient, so you should see him. And there were about 10 on his list. And 9 of them were in strong correlation. Actually, much of the genetic of the human genome is strongly correlated with each other. So all 9 basically marked the same thing, so it was really one. And then the other allele reported was a PCSK9 loss of function variant, so it was actually protective for CAD. So I think and that guy had had undergone so much different testing, none of which really panned out to confirm that he had high risk for coronary artery disease. So I think it's important understanding what these disclaimers are. But now is an opportunity where patients can come to us with this information. So as I said, it's important to think about what their risk factors are. If you somehow confirm that there is a high genetic predisposition, lipoprotein A is, I think, an important thing to consider. It forms, a good fraction of the polygenic score, and certainly not the majority, but what is not assessed often by conventional risk factors. As I said, cardiac CT may have a role in this setting that requires future work. And then, I think for everybody, diet and lifestyle modification is key. If patients are coming to you interested in this, I think that in itself can also provide a unique opportunity for that kind of counseling, regardless of what the score is. And then also, statin therapy may be reasonable. I think it's worth thinking about a wide variety of things, not just the genetic risk score in that setting. So I'll end it here. My lab has been around for less than 2 years, and it's grown in size, and had the fortune to work with a bunch of very talented people, and it's been a lot of fun. So I'll take any questions. Dr. Sperling.
So first of all, great presentation, and congratulations to your group on really, really important work. I mean, you're pushing frontiers that will be important in terms of conceptualizing future approaches to cardiovascular prevention. In our 2018 guidelines, when we constructed the risk assessment algorithm, we kind of now refer that to CPR, calculate, personalize, and reclassify. Mm-hmm. And so if someday we might use polygenic risk scores in the clinic, and I think we're at the point of considering that. Where would you see that in that algorithm? Because you pointed out at birth you can predict risk in one's life. So should we follow that algorithm, and then after we get to the reclassify with CT calcium scoring or subclinical measures, then whoever's left over after we go through the risk-enhancing factors, which also do include Lp(a) and lifetime risk and inflammatory diseases, on and on. So where would you stick that in that algorithm? Yeah,
these are excellent points. I think it's important to conceptualize that A genetic risk score is a continuous score, and I think so. That's one. So I think for younger individuals that the conventional risk factors may not yet have the discriminative capacities that they do later in life. That may be the only risk factor, and for those individuals, the tails, somebody who's at the top 5th percentile or 1st percentile, that in itself may be compelling to start medicines earlier, and maybe there may be an appropriate age cutoff. For individuals that are in middle age, which is the big part of the cholesterol guidelines, I think there is at least less controversy in that middle ground where there is some degree of equipoise. I don't think there is yet enough information to say that individuals who are at very low risk, who have a high genetic score that is not necessarily in the tails, would move you up into a compelling degree, at least to intermediate risk or even high risk, and certainly not at the high genetic risk that a low score will offset and trump the clinical risk factors. I think the sweet spot for the middle age would really be in that middle, and to use it comparably with a risk enhancer. I think many people think that genetics should be treated differently, and I think it really should be treated differently really more in the younger individuals and less so in the middle part.
I was going to ask
Yeah.
two more. Have you looked at all at people at high population-based risk who have a low genetic risk score? Essentially, can you de-risk them like a 0 calcium score? And then atherosclerosis is a gene behavioral environment interaction, and we know that socio-demographic factors are a key piece of this. And so you talked about how lifestyle and behavioral approaches can mitigate genetic risk. Have you all looked at SES and how that might move the bar?
Yeah, so we've definitely looked at the high-risk part, and so this notion of de-risking people who are at conventional high clinical risk was really advanced in these 2018 guidelines. Many investigators responsible for this work. Low coronary calcium is associated with low absolute event rates, so if somebody is predicted to be high risk but has a calcium score that's 0, that in itself would be reasonable to withhold a statin based on clinical intuition, actually not necessarily supported by a clinical trial. For genetic risk score, so many of these individuals are probably at low genetic risk and or also did other things, favorable lifestyle or for whatever reasons to have a low coronary artery calcium score. But individuals who have, a bunch of clinical risk factors that have a low genetic score, it doesn't move it down to a very, very low absolute event rate necessarily in that setting. So, I think many people in the field would not advocate using a genetic risk score to de-risk people. Really, I think to identify people who are at risk. These other issues that are also I think arguably early risk factors as well too. Parent socioeconomic status, where people are born, where they live, where they grow up, are all important exposures that I think should be encapsulated in the concept of lifetime risk, even for younger individuals and even short-term risk for younger individuals. Those analyses are tough, right? Because I think when trying to estimate what an exposure's lifetime risk is, you need a cohort with very long follow-up, and many of those cohorts don't follow contemporary clinical practice today, at least when you go back and look at what was done. So I think those are hard to do. I think what is helpful is at least there is some stability of the exposure of genetics to try to simulate that. That was done in that UK Biobank paper, but those we're starting to do to look at socioeconomic status. Dr. Taylor.
Yeah, thanks for a great talk. That was really interesting. You've jumped between many different databases here, and I guess one of our questions that's very relevant to us in this geography is how well represented is the African American community? I noticed you had some slides on that, but where do we stand sort of from an overall?
Yeah, there's
availability of data?
overall there is a relative dearth. I mean, it still is overwhelmingly European ancestry. There's some South Asian ancestry just based on I think key cohorts that people have championed, but there's recognition of this from NIH. The NHLBI has this newer effort, the Transomics for Precision Medicine Top Med program. I'm very much involved, where a key impetus was to get non-European ethnicities into that data set. So in top med is about 40% of European ethnicity, and then a key part is also African. The Jackson Heart Study is a big part of it, and others. And then, the Million Veterans Program that Peter is a key leader of, overwhelming number of, at least a substantial relative increase in African Americans, but also a significant absolute increase in the number of African Americans that will be studied. I think that will be, key outputs from the Million Veterans Program. So definitely key delta. I mean, a consistent message for at least polygenic risk scoring is underperformed, certainly in African Americans, where I think there's much more recombination. The population history is much more complex. So we obviously need more work in African Americans, but also separately from a gene discovery perspective. If you include non-Europeans, you'll find many new things. The initial stuff for PCSK9 inhibitor loss of function was all in African Americans.
So I was land as far as altering health policy, because we talk about lifestyle, but we see families who have, as far as their lifestyle and what they eat, they end up being thin, and we see families who they're all obese. So where's the current state of that?
Yeah, I think in the best case scenario, we can, we had an infinite pot of money, we'd be able to more effectively implement a variety of public health strategies indiscriminately across people, and also bring LDL cholesterol vanishingly low. I think the reality is that such large-scale preventive efforts are costly strategies, and I think they're often challenging to advocate for. So many people have taken this, can we better identify high-risk individuals and focus the efforts? And some of that is when people have established disease, and including key precursors like obesity. On a related note, just last week, there was a paper from Amit and Sek and Cell basically describing a new genetic risk score for obesity and advocating this approach to identify, and part of their paper, they were showing that there was discriminative changes even very early in life. And there was a fair amount of overlap early in life, but that became much clearer in early childhood. So if you identified those children early in life who are genetically predisposed, you may want to really step that up. But separately, there are lots of people who get obesity who are not genetically predisposed for a variety of reasons. And the non-genetic causes are really responsible for the systemic changes in the trends in the U.S. And those root causes are challenging to address. I mean, that's, I guess, some of the realities. But I think all that is complementary to the work that we do. The separate gene discovery efforts, there was another from another group in Cell also then that identified also one particular gene, the MC4R gene, where if there was a disruptive mutation, those patients naturally seem to be full. And so that could be a new therapeutic target. So you could also imagine, regardless of the etiology, regardless of the genetic predisposition, there can be a complementary separate medicine. But there really are urgent public health needs to address this systemically and systemically early. And I think to convince people, one way we can start is by improving how we predict risk for younger people.
Yeah, thanks very much, Pradeep. That was great. hard to keep up with you guys. So, you know. So one of the things I found very helpful was your mentioning very little physical findings for FH patients. And some of the guidelines for diagnosis of FH include physical findings. And there are about 3 or 4 groups, as you and I know. I think it does something of a disservice when we have an adult in front of us, especially an adult who's 40 plus. The way to identify heterozygote FH is to measure the lipids. Do the physical exam, but it's likely to be negative. You're not going to find anything. You know, we have thickened Achilles tendons. I find actually that's one of the most sensitive. We have arcus, which is relatively useless after age 40 if you have dark pigmentation in your skin. You have xanthal asthma. Those have typically been taken off in the modern era by a plastic surgeon. They might come back, but they're gone. And you have tendon xanthomas. Often also a partially treated patient, they're gone. Everything's gone. You know, for instance, the true homozygous FH patients who are now getting treated, the lesions are evaporating, so to speak. They're just not there very much. So number one is get used to measuring the lipids and relying especially on that. The question I wanted to follow up, though, was Larry Sperling's, because you're in a clinic, and if a patient comes into you, maybe not this year, but it's going to get mature in the next year or two, and he says, you know, I've got potentially I could get a CAC score, I could get a CRP, I could get a couple other things, but I've already got this genetic risk score because my brother has early heart disease. And do you think that's where we're going to be in 3 to 5 years, that's going to be incorporated into a guideline like what Larry Sperling was talking about? And how will we effectively use that information?
Yeah, I do think that, one, I think it should be incorporated in a guideline because patients are going to be coming to us, and not everybody will be savvy enough to like tease out these different things. And it's a little bit of the Wild West. But I think it will move forward that there will be some clinical product that is of reasonable repute, but I think we all have to understand how to use this. So I think incorporation of the guidelines will be helpful, but I think it will go one step further probably in like 10 years because it's very cheap for a health system to do this, right? I mean, in the VA now, there's 800,000 vets where we just have the genetic risk score. Imagine that gets released into the healthcare system. And a healthcare system may feel that investment of genotyping, which today is $50, which will be less, going forward, and you can calculate polygenic risk scores for everybody. The genotypes are stable. The genetic risk scores may vary, and you can imagine in non-Europeans it will get optimized, but that's just separate computation. So this is likely to move forward to a risk factor that is available to all of us that we have to incorporate. We can't just ignore it because it's going to be there. And there should be some general guidance on what threshold should we consider? Is there an appropriate threshold in the setting of additional risk factors? But I think that really requires AHA, ACC, and others to come together at this, I think, key juncture before it gets released. And I think the pace of the precision medicine initiative and various other strategies of incorporating genetics into the clinic is, I think, really spurred based on the public's assumption that these are important things that we should know about that will be helpful in preventing various things related to their health. So it's going to be in the healthcare system before we have like 10-year follow-up primary prevention clinical trials, which will be required to adequately power these kinds of studies. So I think before getting that, we need to start to incorporate. But I think it's going to be there at the systems level. But I think it's important to think about it that it is another risk factor that's going to be available. There'll be a specific number. We think about it in the context of additional clinical risk factors, and I think there are separate opportunities for younger individuals. So I don't think we need to think about the complexities too much.
Thank you. That was a fantastic talk. I just wanted to use your talk to advertise all of us that we are also part of here at Emory. And any of your patients in clinic or inpatients are eligible for it. Just ask. There are a lot of coordinators and people around looking for them. I just wanted to ask one question, and that was the chip data. Mm-hmm. That would come, as it were, for free when you do polygenic risk score, potentially.
So technically the technology that you need for clonal hematopoiesis or CHIP or clonal hematopoiesis of indeterminate potential is separate from the direct-to-consumer array testing for polygenic scores. You need next-generation sequencing because what we're detecting, so an array basically has a pre-specified list of genetic variants, and it's 0, 1, or 2 for the dosage of the alleles. For clonal hematopoiesis, we're saying somebody is not neatly a heterozygote of 50% of the reads, but it's somewhere, it's like 10%, 2%. For that sensitivity, we need next generation sequencing, but whole genome sequencing, which is not routinely done by any means in the clinical setting and certainly not in the direct to consumer testing, can give you all this information for free. So right now, the array is like $50, but there's a good chance in 5 years, whole genome sequencing will be $50. That you can get this information for free. So.
And while we're advertising for all of us, Mike, if I could put in an advertisement, since we're talking about genetics, if you could inform people of the genetic cardiomyopathy study that you have.
Oh, yes. As we wrap up here, we do have a clinical trial that on the site PI on looking at people with Lamin cardiomyopathy. So if you have any patients in your clinic who have come along that have Lamin cardiomyopathy, send me an email so we can take a look at them.
You have a therapy.
We do have a therapy. This it's an interesting therapy. The trial, we can get into the details of the trial design. I think it's not ideal, but if it happened to be positive, it would be a complete game changer for genetics within cardiology for the first time ever. So. All right, we'll wrap it up. Thanks everybody for coming.
The preceding program is copyrighted by Emory University.